Stephen, Vlad, come up here. Jane, why don't you come up here too?
Take my Cheetos or?
Yeah, you can bring your Cheetos.
One of the questions about the neuromuscular junction and neuromuscular block. Anybody doing it?
You can sit back down.
Okay.
We have a I was going to have you fill in this.
No. Oh, yes. I have a really good picture.
Vlad.
Just waiting for another prep.
You just have to be an examiner. How's that?
I love going over this stuff.
Right, so this is why it's not straightforward. Just remember when you're reading the questions, not to just rapid fire read the questions. Like, you can ad lib a little bit too. Like, the idea is that you want to give them a chance to explain something, get the question, and like questions. So that's the way it's set up right now.
Like a pressure support rep. She was like,
Okay.
yeah. She's like, I was more nervous than I was. And I was really nervous.
That's not a good word combination. Yeah.
It's October, November.
Oh yeah, I didn't like, oh yeah, I was back. I was like, they gave me a card. And I just
Over there.
and I knew that they told me that I was the person.
You knew that these things need you more.
I gave you this one.
Are you starting down Sunday?
Yep, I'm staying down there. So,
Thank you.
I'm driving down there Saturday morning, so.
Do you know of anyone who's driving down Sunday?
I was thinking about it.
You're supposed to picture.
I'll pick a few.
Okay, Janine, come
Driving
down.
a car problem.
So the format we're going to have for this, the CA3s are going to be the examiners for this first part. They have their stems and questions. I've handed the CA1s the stems. These are going to be sort of like
They're examining us.
that is correct. So I think if any of the CA3s picked you out, then you can hang out with them. The CA2s, you guys are free to go to any group that you'd like to kind of listen in. And then for the second part, we'll do where I'm the examiner, and the CA2s will be the people that will be examined. Okay.
Don't worry,
Sound
Janine.
good?
We've got the main one.
Dr. Ellie, did you bring your Dude, when I interviewed at the University of Chicago, the chair asked me that question. I walked in the room. He's like, "Did you guys have Kleenex for this?" And I was like, "What do you mean?" It was also like the end of January too. I was like, "I am not coming here.
I don't want to do this.
Yeah. And then I think I got home and emailed Dr. Hawkins and said, "I'm ranking you guys first."
Did you pick anybody, Stephen?
No, I was waiting.
Why don't you take Ted?
All right, let's do it.
Shelby, why don't you take Nick?
Yeah.
And then you can stay with Vlad.
Good. Yeah. No, I did not bring my Kleenex flat.
You guys will be the ones.
Mike? We should talk in code. Testing. Syllabus. So you will receive questions between cookie bites.
Oh my god,
Perfect.
All right. I will let you read your stem.
Just the first one.
So yeah. Just the first one.
Debrief after each step.
So I'm gonna.
I love it. Love it.
being sarcastic?
No,
Oh, really?
I really enjoy it. It's kind of a tragedy in a way.
Yeah.
That's right.
The way it works is that they, and then the plan goes, and then the next question.
Few pages.
Or is it just start?
Yeah, it'll be chronic pain without the chronic problems. Yeah, that's what I say.
Okay.
Give that a little look-see. I hope you're a fast reader.
I just read the first one. Did you want me to read all of them? Okay.
First one's good.
And I'm Sarah. I don't think I met you yet.
Oh, I'm Nick. Oh, nice.
Okay.
See, this is a CA2 move. She's annotating, and you wrote nothing. Okay.
It's all up here. So,
Steel trap.
Okay.
is it a
Right.
male again? Is that, yeah. No.
Okay. So, I actually haven't read this down either. Does someone want to summarize it for Sarah and Shelly really quick?
Yeah, so it's a 33-year-old gentleman, heavy, obese, who was assaulted. GCS was normal. He has some risk factors for OSA, including his 135 kilo weight. They had to wire him shut at the end of the case, and now he has a nasal intratracheal tube in place and vital signs are stable.
Great. So should this patient be extubated in the OR at the end of the procedure? Should he have been?
So I think it depends on his like he needs to, just like any other patient, needs to meet like extubation criteria to be able to be extubated at the end of the case. So including if I felt like he was maintaining well, able to follow commands, and therefore able to like protect his airway, as well as like strong enough to like pull good tidal volumes and not have a lot of airway edema, then I think he could have, given then his vital signs are stable as well, I think he could have been extubated.
Do you think that he would have a harder time meeting your criteria for extubation based on the stem?
I think there's definitely, I think there's definitely a possibility he'd have a harder time meeting criteria, given that his mouth's wired shut. So there's only way for him to like ventilate himself is through his nose. So, and given that he was intubated through there, that he, I think the chance that he has airway edema from that as well as from the original injury would be a lot greater. So I would be very observant about those factors, but I think it's still possible that he'd be extubated.
Is there anything you'd like to have available prior to extubation?
I would want equipment with me to, if I needed to emergently re-intubate him, if I were to extubate him, and then he was not able to like keep his airway open and keep his vital signs stable. So I would want to have another nasal endotracheal tube. I would want to have I would want to have like a fiber optic equipment for a fiber optic intubation in the room, because that's the only way I'd really be able to re-intubate him. And then I'd want to have equipment in the room if we needed to do like an emergency crike to gain an airway that way.
The patient's slow to emerge and remains mechanically ventilated with no spontaneous effort. What's your differential?
So residual anesthesia, he including like all, and then also like if he has like too many opioids on board that could cause those symptoms. He could have had a head injury that was not initially diagnosed, even though when he came in with, it kind of presumes he came in with like full GCS. But, a head injury could kind of present later in the course. I think those would be the things that would be at the top of my differential.
How are you going to assess him and make a diagnosis?
I think given the mechanism of his injury, if he were slow to emerge, I would probably pursue like a head CT.
Assume that the patient just had an opioid overdose. Would you give an antagonist?
He's still intubated. I do know how to answer questions. Assuming he's still intubated, I think I would give. Yeah, I would give an antagonist. I would just start with like a low dose and kind of titrate up,
What's
see
a
if
low
it had an
dose?
effect. Don't ask us doses. Don't worry there.
I'm asking you.
I would probably start with like 0.04 milligrams. Yeah,
Yeah,
and
it's
then
when you dilute it in intensity, so you can give
yeah, 0.04 because it comes in 0.4. So I'd start at 0.04 and then I would do aliquots of 0.04.
What are some consequences to reversing opioids?
Well, you can certainly reverse the analgesic effect that they have, so that could put the patient in pain. You could, you basically precipitate like withdrawal symptoms, so they get tachycardic, hypertensive. Yeah, that would be my answer.
So you give naloxone, the patient opens his eyes and vomits with the ET tube still in place. What do you do?
I would suction. So I would put him in a head down position to prevent the vomitus from like going into his airway, and then I'd roll him laterally as well, and then I'd try to suction like through his nose. That's really the only place that I have to suction through, and suction through the ET tube. Make sure nothing was like in the lungs.
How will you minimize further risk? And when will you extubate him? Aspiration.
Minimize further risk of aspiration. I would give antiemetics. I'd probably, assuming I didn't give Zofran beforehand, I would give a dose of Zofran. And
Is all that's nauseous vomit? Does all that nauseous vomit?
Is nausea the only
It's
thing that
like-
causes vomiting? Is that what you're trying to
Yeah.
Gotcha.
Well, it's like sorry. I shouldn't be breaking things. Never mind. No, it's like that. Not all the wheezes is asthma. Never mind.
oh, gotcha.
Anyway.
It's all that not. Yeah.
Yeah. Sorry. I'm trying to keep my resting bitch face on. Keep going. I'm not nodding. I'm not nodding either.
Mic right now.
This is very challenging. Oh shoot. No one's okay.
There we go. Hat's over it.
When will you extubate this guy?
I mean, he would have to, again, needs to show me that he's strong enough to like pull good tidal volumes, that he is conscious enough to protect his airway, and then that he's not going to, and that he's not feeling nauseous. I'd add that to my extubation criteria because I don't want him vomiting with an unprotected airway. And a wired jaw, his jaw wired shut.
How are you going to assess for nausea in this guy? That you've just ripped the opioid comfort blanket off of him, and he's probably got some other drugs in his system, by the way. Popular nightclub, I just assume.
I mean, other than like that goes along with my extubation criteria. He has to be like awake enough and with enough to be able to answer my questions about if he's nauseous or not.
So assume he's spontaneously breathing prior to opening his eyes and vomiting. Does early extubation minimize the risk of emesis?
I wouldn't think so, but I don't know. Based on my general experience, I wouldn't think so, but I don't know for sure. I would ask a colleague.
I would phone a friend. Okay, let's get through. It's really hard not to nod during this, by the way. All right. Okay. Should your patient be extubated in the OR at the end of the procedure? So I think you did a good job of talking about your concerns. The big concerns being, so this guy has his jaw wired shut. He's likely going to obstruct in PACU, and you have it be challenging to replace that too. So I think you were on the right path in saying that, my concerns would be that he'd pretty much have to wake up and ask for the tube out. It's kind of like kids where you're like, they essentially need to wait. They need to, they're like 6 months old, so they need to grow old enough to ask for it out. Obviously, let's see, special preparations for extubation. One thing I like that you're thinking about all the airway equipment you could possibly get. One thing that you didn't mention, which is probably just an experience point, is you should actually have wire cutters. Anybody whose jaw's wired shut, those should be available.
And then you can orally intubate because you're not going to get that tube back in fiber optically in a shit situation.
Right, especially if you've tried something like nasally re-intubating him, or even having done it in the first place, you're going to have a bloody airway. Presuming he was nasally intubated the first time around, I mean, he obviously has a clear route, but it doesn't mention any sort of facial imaging. He has multiple fractures. Like, you don't know exactly what you're sticking that tube into. So yeah.
I have a question.
Yeah.
So there's a lot of information required for extubation that we don't have in this stem, right? Like, I don't know how they intubated him exactly, how difficult it was. I don't know what time of night it is. Who's going to be taking care of him after this? Like, can nobody else in this hospital intubate?
So I think those are good things to come up with. So in an oral board situation, they won't give you any of that information. You're not allowed to ask for any of that information. And so
You can't ask for it?
No,
Okay.
no, do not. That's like rule number one is like, don't ask your examiner questions. It like pisses them off. They get angry and they're like,
they really? Okay.
yeah, honey badgers. So, so I think it would be appropriate for you to be like, assuming he was an easy intubation, or assuming you get to assume a lot of things. And if they don't want you to assume that, like, you just have to vocalize that assumption, because it shows that you're considering those things. If they don't want you to assume that, they will correct it.
Okay,
They'll
so
be like,
assuming that I could easily intubate him orally if wire cutters were in the room, assuming that somebody who had experience with airways was going to be taking care of him later on in the night, he meets oxygenation and
or like, considering the variability of people. If maybe this is a guy, you could be like, maybe this is a guy, depending on how he looked after extubation, would maybe require ICU monitoring.
yeah, okay.
All those things. But yeah, you have to like vocalize that assumption. So, okay, he's slow to emerge. I think you did a pretty good, like, I think the differential doesn't have to be exhaustive. You want to give like your top bunch. Young guy, trauma. I would say the only other thing I would include on there is the potential for having like multiple drugs in his system, some sort of interactions. And then I like that you thought about a head CT, but I think there's some low-hanging fruit prior to that, right? You could send labs, you could do a blood sugar, things like that. And as far as naloxone, they will ask you drug dosages.
Oh, really?
Yeah. So you can, if you don't know, you can say, like, I'd have to look that up. That's a very reasonable escape plan. But yeah, those are not off the table. Like, I had one practice one where they asked about the dosage, like ACLS, like for pediatric ACLS, like epi-dosing. And I'm like, yeah. So dangers of reversal, like you're thinking of, like, no one's gonna die if unlike flumazenil, I feel like we all think about like seizures, right, as the big one. You're like, oh, they'll just go into withdrawal. But pulmonary edema is a big one. Yeah.
With Narcan? I didn't know that was mechanism.
Is that with Narcan or with opioid withdrawal?
Narcan,
Okay.
specifically. Considering I was told I was wrong when I just assumed it was like an extreme pain response and like a negative pressure, like pulmonary edema, I'm not quite sure. But it is flash pulmonary edema as a side effect. So.
I guess my other concern was Narcaning him would be getting into like an uncontrolled pain situation. This is a young 135 kilo guy who has a precarious too. Like, I don't want to get into some uncontrolled situation where he extubates himself.
Through his nose.
I think that's why you're not giving him.
Somebody got cranked in the unit for that.
Yeah.
Yeah.
It was like hanging by a thread. It was like, well, I think, then you would just vocalize the concern of, like, obviously this is a tenuous airway in a gentleman who's probably got a lot of substance, potential for substance use disorder, potential for uncontrolled postoperative pain. I would just say, I mean, it's all in the dose.
Yeah.
So just kind of vocalize your concerns that you would go slow and titrate to effect. And you would look for a return of spontaneous respiration rather than sitting bolt upright. Sorry, reading this upside down is very challenging. So you gave naloxone. You did well with the aspiration. The only other thing I would add is that you could drop like an NG tube, kind of suction them out. So I know you were suctioning vomitus out of the mouth, but you could go even further and just get it on out of there because I assume he was an RSI for that full stomach situation. So, yeah. I don't know if y'all have had a patient PACU yet that feels no nausea, they just like spontaneously vomit. So that's kind of where I was going with that.
Yeah.
There may be no warning whatsoever. There is a chance that an early extubation would reduce your risk of emesis. But I think that you were right in the sense that like the better part of valor is to just, you're considering an airway and a guy that would be challenging versus the risk of, I'd say the risk of losing his airway is worse than puking.
So if they puked with the endotracheal tube in, would that be an indication to like cut the wires like from the surgery? Like basically other than like we extubated and now he's like crumping, so we should like cut the wires then, like what else would be an indication for like cutting
This
wires?
feels bad to let them with it.
Right. It's really nasty, but provided he can protect his airway, he's not going to inhale it. The concern of aspiration is not protecting your airway. Once you're protecting your airway, it's going to be really gross for what I presume is a good long while.
Right.
But it's not a danger per se.
Gotcha.
From an airway.
So if he's in PACU, like fully awake with it and extubated and then vomits, you would still be like, he has enough wherewithal to still protect his airway and would be able to swallow all
I
that.
think you would get to a point. I think it's going to be a judgment call. Number one, if he had Panda Express, like at the nightclub, like this could be a problem. But I presume a lot of times it's like a retching and a fluid, that can kind of come out. But I mean, that would also be. It's completely legitimate to say, like, I would talk with the surgical team about, like, if they felt that it would be reasonable to cut the wires and rebar him, essentially. But yeah.
Gotcha.
I mean, if he kept vomiting, you're at a point where you kind of got to.
Sats are dropping. Like,
because he didn't cut the sutures for a hematoma that was forming after a thyroid surgery, and he lost the airway. He was sued for not cutting the sutures personally.
I feel like that's always a question you get. Like that's been. But what's interesting is when you talk to the surgeons, the first thing we always say when they pose that question, the first thing we're like, "Cut the sutures," and the surgeons are always like, "Do not cut the sutures," because we have a heart in the CTICU where they were like, "What do you do if you're you see like tamponade physiology in an open chest?" And we're like, "Rip it off, let that puppy breathe." And he's like, "No, actually, it's probably tamponading like a rip in the RA or something. And so if you open it up, you could exhale."
They'll just exhale. Well,
like
fix your problem.
rock in a hard place, right?
Interesting. Okay.
All right, take a peek at the next one.
Everybody's so fat. All these.
This is America. I rolled in here eating like cookies and Cheetos, so I'm not throwing stones.
Oh, yeah, sorry.
Okay. Patient is positioned prone and the surgeons are proceeding with exposure. They immediately note that the patient is diffusely bleeding. What is the likely cause?
What is the likely cause? The trauma compounded from the fall, compounded by the blood thinner, feeding the blood thinner.
Okay.
I think is the likely cause.
Will you order anything? What are you going to do about it? How are you going to look at this?
I would definitely order, given the patient's history of requiring multiple transfusions from like other issues and being on the blood thinner and diffusely bleeding out, I'd order like emergency blood for the room. And then I would order something to try and reverse the dipiatran, but I forget what reverses that.
I'm looking it up right now.
Because I think like I don't think PCC or FFP would.
Apixaban had Adnex, so that's what I gave over the weekend. It's $175,000.
Yeah.
The reversal.
Yeah. Do you want to order any labs? Is there anything you want to do to work it up rather than just having blood in there?
I mean, I'd probably order I'd order a CBC and a TEG and PTINR and a PTT.
Shortly thereafter, the circulating nurse notifies you that the patient has antibodies in his blood and that the cross-match blood will take several hours to get. Does this change your plan?
So if assuming the patient's vital signs remain stable, then I would call, assuming they're stable currently, I would call the blood bank and discuss with like the pathologist about what could possibly be the safest thing to transfuse at this point in time. Yeah, so that's what my plan would be, assuming the patient's vital signs are staying stable.
Is there anybody you can't give trauma blood to?
Well, based on like the antibody screen, like the patient does have a risk of having like a reaction to trauma blood. So that's why I would want to call the pathologist to discuss what they thought might be the safest course of action based on the screen.
Are any other blood products or concentrates indicated?
Assuming the patient is getting into a situation where it's like a master transfusion type protocol, then I would be wanting to give like FFP as well as red cells and potentially platelets to keep my ratios of products even.
2 units of cross-match blood are now available. If the patient continues to bleed excessively, how will you determine when to transfuse those RBCs?
I would go off of a couple different factors. So certainly if the patient's vital signs started to become unstable and they're getting tachycardic and hypotensive, I would transfuse at that point. Otherwise, I'd probably go off of a hemoglobin. Given his history of coronary artery disease and CABG, I think my low-end threshold would be a hemoglobin of 8. So I would transfuse below that, even if his vital signs were stable. So those would be, I think that would be my decision-making tree.
The blood pressure is 80/40 and the pulse is 110. So you give both units, but the vital signs don't change. How do you plan to manage?
I would. So my differential for the hypotension at the top of the list would be like hemorrhagic shock, causing this side order more blood to the room, and with the intent of giving that, I'd also place I'd want to have an arterial line and a central line in place, a central line to start vasoactive agents. So I think those would be my two ways of managing it.
Okay, what do you plan to use as far as vasoactives?
All right, so this is so basically, yeah, this is kind of like a situation where
I think I would start with norepinephrine as my main agent. And then I would probably I think at this point I would also, if we continue to be in shock and not responsive to my fluids or minimally responsive to my fluid resuscitation, I think I'd want an echo, like a TE as well, to assess like cardiac function. If the patient was showing to have like decreased cardiac function, then I'd probably want to start epinephrine or debutamine to help with my inotropic support as well.
Okay. What else is on your differential for hypotension?
So for this patient, my top two, like I said, was I think hemorrhagic, given the reason we're in the operating room. I think cardiogenic shock is also on the differential, given his cardiac history and having a CABG 2 years ago. He, I think, less likely would be like. Well, I guess distributed shock could be like a neurogenic shock picture would also be on my differential given the epidural hematoma and that he was symptomatic from that with cardiac Aquinas syndrome. Less likely, I would think about obstructive shock, but I think that would be less likely like a PE or something like that. I think there's other things right now that would lead my differential that I mentioned.
You begin to see signs of ischemia on your EKG. How does this influence your management?
Again, given the situation, I feel like the reason for ischemia is like low coronary perfusion caused by either the continuing hemorrhage that's going on that we have not resuscitated adequately, or if we did do a TEE and it showed issues with cardiac function, then that could be an issue as well. So I would continue with like a massive transfusion protocol, trying to replace as much of the blood products lost as possible, as well as providing like inotropic support for the patient.
How does it affect your pressor choice?
The signs of ischemia. I want to try to optimize like my myocardial oxygen demand to supply. So in order to optimize like supply, I would want to try and like slow down his heart rate and reduce his afterload, or reduce his like wall strain that the heart's seeing. So I don't know.
There's I was being kind of mean because I feel like you did a good job talking about kind of your goals. So I'm only being mean because you're doing a good job. All right. So patient is prone and you've got immediate bleeding. So obviously I feel like you did a good job pointing out dabigatran. In fact, he was a trauma patient. He's probably coagulopathic, probably got some bleeding concerns. It's also a fair chance he's gotten some resuscitations. He could be could be sort of dilutional coagulopathy at that point as well. So you did a good job. I think ordering your labs early is really good. So you eventually got to CBC, TAE, coags, things of that nature.
So what is dabigatran going to show up as on those studies? What's going to be normal and what's going to be abnormal?
I think all your like PT, PTT, INR, I expect those to be relatively normal. And your tag, I don't know about the tag. Like maybe you'd have a prolonged R time on the tag.
Have you guys seen it on any tests before?
Looking at the mechanism right now.
So prolonged R and your angle also.
Your angle,
is
okay.
affected.
Martini
So
Clot strengthening, yeah.
it
the angles.
looks a lot like a factor deficiency, right? Because you're blocking the
Because
factor.
that's what it
Yeah.
is.
But the question is how are you going to treat it? Now, I came in a little bit after you started it, so I didn't hear this. Did you mention the antidote for dabigatran?
No, I can, because it's a direct thrombin inhibitor, right? Yeah, so like PCC, FFP, like none of those work
Right.
for
So
this.
have you heard of the antidote?
I didn't hear it for dabigatran. I feel like there's one for.
How about you, Rolly?
I don't know which one it is. I'm looking that up right now.
So I don't ever pronounce it right, but it's like idarucizumab or
Yeah.
something like that. So it's a monoclonal antibody, and it's directly antagonizing dabigatran, made by the same company, sort of like the Rock Sudamidex combo, right? So they essentially made something that they knew was going to cause problems, and then the reversal agent to get rid of those problems. Our hospital has that, so that's what you would give, especially if you have to do this procedure. Patient doesn't have blood immediately available. That's what you're going to go towards. So prior to this agent being available, PCCs were kind of looked at. Do you know the difference between a 3-component and a 4-component PCC?
No.
Do you? Do you? 4-component essentially has factor 7. 3-component doesn't. So the 4-component is the only one that has been shown to actually be helpful. So if you have a 3-component PCC that you're giving, you're not going to reverse kind of this coagulopathy from dabigatran.
The other 3 components, it's like 8 fibrinogen and von Willebrand's factor. Is that?
So PCC works really well. They've done studies looking at factor 7 in higher doses. Factor 7 in higher doses can also be helpful, but none of them are very good at baseline. Like you might help some in terms of bleeding, but it's not great.
As predicted, right? Like mechanistically.
Yeah. There was this really cool patient that was involved in one of the studies for dabigatran, where this patient was in the study for, I think it was for atrial fibrillation, had the need to have an urgent cabbage. And they were able to follow this patient through their intraoperative and postoperative course, looking at what all these PTT values were, and administration of PCCs and factor 7, and what it took to get this person to stop bleeding postoperatively was actually hemodialysis.
Wow.
Because nothing was really working. The patient was putting out like 1 liter or 2 liters of blood through the drains postoperatively. So they were just essentially transfusing as fast as they could and had to go back to the operating room. Initially, they looked for what they thought was a surgical bleed, found nothing. It was just oozing from everywhere, and then had to get dialysis. So this was a little bit more in depth than kind of what you covered. From an examiner standpoint, could have harped all over what do you do for dabigatran when it's at a therapeutic level in a patient that is bleeding? Right? It's something that you will see. So if you don't know, then you got to say, well, I would consult with my hematology colleagues to find out what our facility has available and what they would recommend. Something like that.
Can you say like pharmacy and blood bank too?
Yeah.
Yeah.
I mean, talking to somebody else, right?
Yeah.
If you don't have the exact answer.
And you'd mentioned antidote, but I think we gave up on that pretty quickly.
Yeah. Well, I couldn't remember. Yeah, because you brought up there's an antidote to like a Pixaban.
Because I got to get it
That's-
for a training.
So
I don't know about that stuff. I
Which
don't
one
think
was
it's going to
it?
stick
That
around.
that one's called.
Andex or Adnexa or Andexa.
Yeah.
But
Alpha, right? Something.
when
alpha.
they went to evacuate the subdural, and it was just a rubber chunk at that point. And I was like, that's what the rest of your blood looks like too. I just drove peaked at like 60.
Yeah, so that actual agent that you're talking about would be then an agent for all the factor 10A inhibitors, right? So they're Pixaban, Rivaroxaban, Edoxaban, there's like a bunch of them.
right. Yeah. So then I can. So I remember when like stuff. This is like relatively recent, like these reversal agents
Yes.
for the NOACs, and then I was like, oh, is there one for like the direct thrombin inhibitors? But
Yeah.
there is. So that's good to know.
And when you don't know, just say, I'm going to consult with whomever you think is the most appropriate person to figure that out.
Clark.
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 Local
It's
bill.
2 a.m. Clark.
All right, so the antibody question with the blood.
What would you have done?
Me, same thing. Would have called the blood bank, called the pathologist, ask him what my temporizing options are. I mean, if you need blood, you need blood.
What would you have done?
Yeah, there's a question like this on TrueLearn, and so you're supposed to call the blood bank and ask what the time frame is going to be, and then in the interim, if they need blood, that's sort of the end of it. Give trauma blood.
Yeah, so that's what I say. If they're stable, I'd call the blood bank. This is exactly what TrueLearn said. And then if they're not stable, then you just give the trauma blood. And
Yeah, so if that second part would have been worded that the patient was hypotensive, you had no cross-match blood available, and you gave trauma blood, and the patient was still hypotensive, what's part of the differential then?
I guess like a transfusion-related reaction. So
So did you have any idea, or was it surprise?
We kind of talked about other products. We gave the 2 units, didn't help. I think you did a good job talking through differential. The only other thing I was thinking was the transfusion reaction and the, this guy fell off a ladder. I mean, he could have an obstructive pathology. He's got, thoracic injury and things like that.
like a tamponade type.
Or tension pneumo, or, we didn't kind of go down that path, but, and then ischemia on this ECG. I think you approached it correctly. You're trying to get his hemoglobin up where you're improving his oxygen delivery. You're using echo to kind of see what if you've got, wall motion abnormalities, if there's any information you can get from that aspect. And then, pressors to temporize.
So what would you have chosen? What agent? Since you were pressed.
Oh yeah.
I know. That's what I was thinking. I was like, I know I'm being a jerk because it's going to come back to me. Because I feel like that's always in my brain. Is I was like, what would I use? I'd be trying to, you've got those competing goals. The first thing I was thinking of is, this guy who's already in, chronic AFib and has issues where he's going to get to a point where he's going to be hypotensive because he's not. So I was thinking my first line would be phenylephrine just because I'm trying to minimize that issue. But I think norepi or vaso, presuming, we don't have any information other than he had a cabbage, but I think it's probably reasonable to use one of those agents.
So I think whenever you're in doubt, you don't really know what you would choose because they're forcing you to choose. Go through the things you definitely wouldn't use. Right? So what wouldn't you use here? Somebody's got ischemic changes. What wouldn't you use?
Well, I guess I wasn't going to use like the afterload agents because I thought that would like worsen my coronary like perfusion and my ischemia. So
Again, you're not choosing anything. I want you to tell me.
Right.
Pick specific things.
oh, so you're saying I should think of those, but then say other things.
Exactly.
Is that what you're saying?
I'm not going to
Like you're saying
give-
say those. Okay.
Pick
I'm
the
not
worst.
I'm not going to give,
the least
let's say,
bad.
if you're going along those lines, I'm not going to give phenylephrine because I'm worried about this. I'm not going to give don't know, dopamine, because I'm worried about this, right?
Yeah.
So that's how you can start making it apparent what you're thinking. Instead of saying, well, I would give, and you sit there thinking for 5 or 10 seconds because you don't really know what you would give. Start off with what you wouldn't give, right? Because that's just informational for them to know that you at least have an idea of what you're considering.
Right.
Like I wouldn't give epi.
Probably not. Now, for me, when it comes to choosing something, when they're telling you to kind of corner you for something, it's okay to say, I don't feel like I have enough information with what I'm given here to make a definitive choice. And you might force them then to say, well, then you've got your echo, you see wall motion abnormalities, now what are you going to choose?
Gotcha.
So what would you choose?
Yeah, I don't know. Norepinephrine, I guess.
What would you choose?
I mean, I think hypotension is probably the reason we're seeing ischemia. So it's not that I'm too concerned about increasing afterload as somebody I would who has like florid heart failure. So I would probably still choose either vaso or epi, whatever I had closest. But I don't necessarily think that one of those would be worse than the other.
Generally speaking, of the things that you're looking at when somebody has ischemic changes on ECG, what is the aspect of oxygen demand in the myocardium that is responsible most of the time for the biggest change in or biggest impact on oxygen demand? Heart rate, right? So his heart rate is 110. So in your mind, your first reaction should be to try to get that down lower. So that's why vasophenylephrine might be agents that you start with first to try to get it lower, combat the hypotension, and just see whether that improves your.
Well, I feel like we had a game changer piece of information with this reversal agent.
Yeah.
All right. Next one. The what? Because you guys are. He's gonna make you guys do the.
I can't move my arm. I just don't want to.
Oh, and you sat around for this? No. You'll be happy to know that we, for graduation, there was like who's the worst black cloud?
Oh no.
It wasn't you.
Oh really?
Yeah.
Was it Ace Rock?
Oh yeah. oh yeah. All right. We got one more really quick. All right.
Because Wilkie and Brainerd don't like reading with me at all.
Okay. So just for Sarah, so we don't have to pass it around. 58-year-old, 5'2", 115 kilo woman, scheduled for an X-lab for ovarian cancer, 2.5 pack per day, smoker until just recently. COPD, moderate, albuterol ipratropium inhalers, and wears oxygen at night. She's got moderate ascites, pulse 104, blood pressure's normotensive, and she's satting 90% on room air. All right, so ventilation is very difficult following intubation. Airway pressures are high. What's your differential?
Assuming that, so my differential, given her history of reactive airway disease and her history of smoking, I would think like bronchospasm would be highest on my differential, causing increased airway pressures. After that, I would consider possible equipment issues, such as like my endotracheal tube is kinked somewhere or my circuit is kinked somewhere that are causing high pressures. And I think those would be the top of my differential for this specific case.
Is there anything about her habitus that you feel might be causing elevated peak airway pressures?
Yeah, I mean her obesity is definitely gonna increase her like intrathoracic pressure and
What
could
else does
therefore
she have
like
other than obesity?
and her ascites as well. So so both of those could increase her intrathoracic pressure.
What do you do about this peak airway pressure?
I quickly check my circuit to make sure there's no kinking or obstructions in that. Then at that point, I'd probably I'd give. I would look at my capnograph and my fluid volume, my like spirometry loops on my ventilator. If I thought were signs of like acute obstruction on there, then I'd probably give albuterol to help with that. If I did not see evidence of like acute obstruction on there, then I think I would lean more towards that this was due to both her body habitus and her moderate ascites. And so for that, I would try to just have a discussion with the surgeon about what are the best ways we can optimize her like positioning in the OR to both allow for the surgery and to like offload the increase in intrathoracic pressure that her abdominal girth is causing.
What could your surgeons do to help knock something off your differential?
What could my surgeons do to help knock something off of my differential? I mean, if we've already insufflated the abdomen, then they could desufflate the abdomen and see if that improves the airway pressures. We could, a lot of times these procedures are done in some degree of Trendelenburg. We could try to limit
Is this a laparoscopy or a laparotomy?
This is a laparotomy. I guess not as much. Okay. Yeah.
So they could drain your ascites.
Oh, okay.
How would you distinguish between bronchospasm from an endobronchial intubation?
Both her capnograph and her flow volume loops would have. The capnograph would have a steeply like upsloping segment. That would look like bronchospasm. You could auscultate. Endobronchial intubation would have breath sounds on the side that's intubated, and the breath sounds on the side that's not intubated, where bronchospasm would likely have wheezing or just really poor airflow, but it'd be solely bilateral.
Yeah, so you have bilateral wheezing. What's the most likely cause?
I think bronchospasm in response to. It could be in response to a variety of like noxious stimuli, whether it's like endotracheal intubation or potentially surgical pain.
What's your second most likely reason?
I guess she could have aspirated at some point, like if the bronchospasm was occurring early, shortly after intubation. She could have aspirated, she could have irritated her airways and caused a bronchospasm.
What's the third reason?
I don't know.
So ventilation normalizes and the procedure is well underway. Surgeon requests a Trendelenburg position. Shortly thereafter, the peak airway pressure alarm sounds again. What's your differential?
So I think even though we just changed the patient positioning, I think the increased body habitus laying on her thoracic cavity, increasing her thoracic pressures, is causing elevated peak airway pressures. Certainly bronchospasm could have happened again, given her reactive airway disease, and that had already happened in this case, but first on my differential would be the patient positioning.
I feel like I think we covered so many of these that we're just getting some skipping ahead somehow. So again, ventilation normalizes, but near the end of the procedure, you note gradually increasing inspiratory pressure over the next 15 minutes. How would you determine the cause?
Highest on my differential would be that the patient's breath stacking, dynamically hyperinflating from her COPD, and so I would I think decrease her IDE time, make the E part larger, and give her more time to like exhale with each breath to see if that would reverse the increasing inspiratory pressures.
Assume a mucus plug is present. How would you proceed?
I would suction through the endotracheal tube to see if I was able to like remove, if the mucus plug was that proximal, if I was able to like remove it that way. That'd probably be the first thing I'd do.
If suctioning doesn't improve the status, what would you do?
Then you can potentially use. I'd have to ask a colleague to help with this, but to use bronchoscopy to see if you could visualize the mucus plug and remove it.
Okay. That's our last one. You did a bang up job. We're just going to talk through. I know I was trying to force you to think about something.
Yeah. Oh yeah, with
not all that wheezes is COPD.
Yeah.
Anaphylaxis.
Oh.
So
Sure,
neuromuscular blockades being a common reason, antibiotics being a common reason. All those things we give about the time you would have noticed this. Chlorhexidine, I've never gotten a non-rash reaction to.
I don't know. I wasn't here.
Okay. Oh, gotcha. So ventilation is very difficult in this lady. I think you did a good job. Your differential, you've got obstructive airway disease. You didn't actually mention endobronchial tube, but you did mention equipment issues. So I would just extend that to be very, very explicit. I think you did a good job in terms of, I think also being kind of like, we've all had that in the OR. I guarantee you have it at this point too, where you hear that you're having those alarms, and so you've got a differential, but you're doing things in order to narrow it down very quickly, right? You're deepening an anesthetic because bronchospasm could be that issue. You're giving albuterol because you could have that issue. You're listening. I think it was kind of funny. You mentioned a couple things before you listened to the patient.
Yeah.
I think that probably would have been a really easy one to like. But at the same
I was saying
time,
those first things first, and then I was like, oh yeah, actually, if you
I
just
know.
listened, that would have solved the problem.
No, but it's a lot of information you're trying to like get in your brain or get out at the same time. So once you have bilateral wheezing, you pretty much know that you're not endobronchial, and you did a good job of talking through that. We kind of talked through this other one. I think a good way to think about it is like you're thinking of like high peak airway pressures, and so you've got a full body system. You did a good job kind of starting with lungs, like intrinsic to the lung issues, and then I would not give up on the patient at that point and move to the like machine and equipment. Just kind of think about what else, right? Like, because this could be fake high airway pressures, right? Like you've got a big belly. You could have all that pressure there. Ascites, actually, I mean, I've had folks that they have to drain the ascites very quickly because it puts a lot of airway pressure on there.
Yeah, I think when you said the question to me, like my thought was like all of a sudden you have high airway pressures, which like you would just have high airway pressures anyway with the ascites, but you should like still think of that. So that's why I didn't think of it.
And it's fair, right? Because we're mentally in two different areas of the case. Here, I'm thinking directly following intubation, right? So they're suddenly high because you're measuring them.
Right.
So that it could be your suddenly high peak airway pressures. Yeah, almost done. Yeah, no, you did the last one. I have like no critique for you. You did a good job.
I think it helps. I just finished studying for basics, so like a lot of that's like still in like that you learn with the calling the blood bank. I'm so glad you brought that up because that's exactly.
Because it was like it had some other answer where it was like why would I think I was like, well, I give the blood.
Right, yeah, I think I said that too, and they're like, no, actually, this patient's stable right now, so you would call the pathologist, and it's like, okay.
You're like, okay, true learn, you're not wrong.
Yeah, but
you're not right.
Yeah.
I had one before where I called the blood bank, and they're like, by the way, you know you can't give trauma blood to this patient, and I was like, what? I feel like that's our default.
Because of the antibodies. Also, they said no, you cannot. Yeah.
So Raleigh, come on up here. Diana, come up over here.
So I think it's always one of
Jane, when you get a chance, come up here.
When I get a chance, come on.
Like October, November.
The hot seat.
Oh boy.
Hot seat.
You got it.
I hate the hot seat. Nice try.
You can still
Nice
talk.
try, Duarte.
I just want Duarte.
We see you over there.
She's trying to hide.
She was. She's sticking.
So for those of you that came in a little bit later, so I'm going to do an exam with the CA2s. So if you want to be able to hear what I'm saying and hear what the responses are, you can kind of come up and around.
We just escaped their lives now, so you want us to do it again? I don't think so.
The way that we're going to do this is you're each going to get one segment. So one kind of question segment you'll get, and then move on to the next person, okay? If you'd like to write something down, does anybody need some paper?
Yeah. Sure. Shelves, will you tell me one of those papers? I have a Sharpie. Thanks. You want it?
I might need a pen.
Can I strip this in half?
You got
one? We can share.
Oh my dead body.
Oh, it's getting aggressive over there.
Oh wait, I have my special pen.
I fear they gave it to me.
Ever since they made the cans.
You ready? So your patient is a 28-year-old woman, 75 kilos, 5 foot 6 inches tall. She's a preemie gravida, scheduled for emergency cesarean section. And it's okay, I'm going to ask you questions that you can answer. She's at 38 weeks of gestation. She has pregnancy-induced hypertension. She's been taking hydralazine for that, and magnesium sulfate. For the last 5 weeks, she's been treated with HCTZ. Past medical history is significant for opioid addiction, and she takes methadone. And they're planning to do a C-section because of late D cells for the fetus. Her current vitals are pulse of 110, BP of 170 over 100, respiratory of 22, temperature of 37.4, and she has a hemoglobin of 9.5. All right. Starting with you. What is the importance of her hypertension to anesthetic care in this case?
So a few things. One is if she is only pregnant hypertensive, or has she kind of pushed into the realm of preeclampsia, and if there's anything else going on with that, I would like to know.
So
Have they done P to C ratio for her? I want to know if they've given her other agents since she's been admitted and they have had trouble controlling her hypertension. And I also like to know her baseline, which she said was 170 over 100, so that as I'm doing anesthetic for her, I can keep her in a range that's safe. There are also
So what's the safe range for her?
so I want to stay within 20% of her baseline, either up or down, of where she's been. And then there are certain meds that I don't want to give her after delivery that are contraindicated. So Methergin, I think, would be the main one that I'd be worried about as far as post-delivery that could make her hypertension worse.
You are talking with the OBs and discussing giving this woman a magnesium bolus. What is the effect of magnesium on the mother and the fetus?
So in addition to lowering blood pressure, you can get changes in mental status. You can get decreases in reflexes. And then for baby, I actually don't know. I don't know if it can make baby sluggish or not.
What is the therapeutic range for magnesium?
I don't know.
How would you monitor her magnesium? level for toxicity?
So if she's awake, I can be doing exams on her. I can do deep tendon reflexes. I can make sure that
How
I'm
do you do a
doing
deep tendon reflex?
Oh man, I know it's been so long, right? So I don't remember actually.
Are there any other ways that you can determine magnesium toxicity before deep tendon reflexes become effective?
Altered mental status. That's the only one I
What
can.
kind of cardiac changes will you get?
I don't know.
You, in this situation, you assume that this patient has gotten an overdose of magnesium. How are you going to end up treating this?
So I can give calcium.
What kind of dose are you going to give?
I would start with 1 gram of calcium chloride IV.
What's your endpoint?
So if I'm monitoring EKG, I want to make sure that I'm not seeing any changes on EKG and that.
What changes would you see?
So I'm trying to remember the hypermagnesemia. I don't remember.
What is the late deceleration, Raleigh?
So it's usually due to placental insufficiency, so the fetus is not getting enough oxygen for some reason.
Is that a bad thing?
Yes.
Is that a reason to go to the ED or the OR then?
Yes.
So let's presume that they've been monitoring this fetus with some scalp measurements, and the scalp pH of this fetus is 7.2. What does that mean to you?
I know the ABG of the fetus looks different than the adult, but I can't remember the exact values.
So in terms of an ABG versus a scalp pH, do you know the difference between what those values are going to show?
I think the fetus is more acidotic, but I don't remember what the normal
Do you know
pH
what the
is.
PaO2 would be? Or PO2?
I don't.
In terms of any other tests that confirm that this fetus is distressed currently, what other things would you be looking for on the monitor?
Possibly variability in the strip. I mean, I know they're having laid D cells, but in between the lates, you could look for variability in
What
the heart rate.
is a reassuring heart rate for this fetus?
Probably about 130 to 180.
So let's presume that this pH of 7.2 is acidotic. How would you treat this?
Proceeding to the OR, and then you could consider. Well, let's see. If mom's blood pressure is already elevated, then I don't think her blood pressure is still at 170 over 100. I don't think that I need to increase her blood pressure. We could consider position changes for the mom and also adding oxygen on the way to the operating room.
Kim, and are there any special considerations for her methadone treatment currently?
You want to make sure she's getting her daily dose of methadone
Why?
so that she does not go into opioid withdrawal.
How does that affect her baby?
The baby will also go into opioid withdrawal without methadone.
And in terms of dealing with the patient in the OR, are you going to give opioids?
If it's indicated for
And what indications?
if she's having pain, does she have a spinal at this point, or does she have any interaxial anesthesia?
She has neuraxial anesthesia.
So assuming that her neuraxial anesthesia works, then she shouldn't need any additional opioid.
Let's presume that she has a patchy epidural and you want to give some analgesia through her IV. What are you going to give?
I would start with fentanyl first.
What dose?
I would start with 50 mics to start and see how she does with that.
Now, is this management that you have planned for her any different if she was not on methadone, but rather on naltrexone?
She would likely require more opioids.
How does naltrexone work?
Oh, it's a mixed
Why would a patient be on naltrexone?
Because it gives them the opioid they need without being able to abuse it. If you don't like orally if you inject it, it doesn't. It has a safety mechanism built into it. I can't remember what it is.
Okay, moving on. Would you administer any additional medications preoperatively to this patient in terms of you're getting ready to go back to the OR, anything that you'd be giving to this patient?
I guess I'm a little unclear on what she has. So she has an epidural that we know is working, correct?
She's getting ready to go to the OR for emergency cesarean section.
Okay,
So she just presented. She does not have anything in place currently.
Her current blood pressure is 170 over 100, but what was she prior to that arriving? What is
She
she
doesn't
at
have
home?
any other records on file.
Okay. Is she having any other end organ issues like headaches, vision changes that would let me know this is like a hypertensive emergency?
What's the difference in terms of your management?
I would consider if she's having end organ perfusion issues as well as evidence of not perfusing the baby very well with the late D cells and acidemia in the fetus, I would probably gently try to control her blood pressure with maybe a low dose.
Are you going to delay going to the OR for that?
No.
What's the best treatment for preeclampsia?
MAG and that's all I can think of.
Let's presume that the patient is feeling like they have some heartburn reflux type symptoms. What kind of antacids are you going to give? Or are you going to give any?
Say that one more time.
Patient's having some reflux issues. Any antacids that you plan to give?
I could give famotidine. I could get a PPI as well, maybe.
How fast does that work?
I don't know.
Any other agents that you would give?
I mean, I could give some Benadryl, but I wouldn't want to necessarily alter her any further.
Are there any things that you would give for antacids that would interact with her methadone?
I don't know.
Okay. Moving on to the intraoperative portion. Would you choose regional or general anesthesia for this patient?
How emergent is the section? We're trying to get baby out as soon as possible.
OBs are saying we need a cut right now.
Okay. So I think that I would choose a general. I would be able to induce her quickly, get her quickly to sleep, and they'd be able to cut right now if I were going to do regional. The fastest thing would be a spinal, but I think that would most likely give her a sympathectomy, drop her pressure into a range that would not be safe for her. So I would do a general anesthetic for her.
So you choose a general anesthetic. What agents are you going to use for your induction?
Etomidate and succinylcholine, I would do a rapid sequence induction. I would assume that she has a full stomach. She also has a gravid uterus, so I'm afraid of her having reflux. Would not try to mask her, and I would do an ET2.
Let's assume that you actually have a functioning epidural catheter in place. Does that influence your choice of doing general versus dosing of this epidural catheter?
I think that I would attempt to dose up the epidural catheter with chloroprocaine. If they get into the operating room, test her, and feel like she does not have adequate coverage and they need to cut right this moment, then I would switch to a general. I would have everything ready for a general, and I would use a video scope.
How long does it take for chloroprocaine to start working?
About 5 minutes.
How long does it work for?
About 30 minutes.
So in terms of, you mentioned chloroprocaine, that's probably, what would you choose given that the procedure probably is going to last longer than 30 minutes? What other agent would you follow that up with?
Yeah, so I would also probably do 100 mics of fentanyl on top of the chloroprocaine when we first got into the room. And then I would start with somewhere between 5 to 10 mils of 0.25% bupivacaine in the epidural, and then maybe 3 milligrams of morphine to give her longer acting coverage through the epidural.
Moving on. Attempts to attain an adequate level with the epidural fail. What's an adequate level in your mind?
So probably about T6 to T4.
So you examine the catheter. This is the epidural catheter, and it looks like it got pulled out during transfer to the right table. How are you going to proceed?
I would proceed with a general anesthetic at that point.
And how would you induce that patient?
So I would also do a rapid sequence induction. I would use etomidate and sucks, and then a video scope to intubate. As soon as the patient is tubed, I'd tell the OBs it was safe to cut, and then I would try to. Or you said how to induce. I'll stop there. That's so many other things to say.
Moving on. After rapid sequence induction and intubation, the surgeon begins and the patient's blood pressure increases to 240 over 140. What's the cause?
Likely pain. So you deepen your anesthetic.
Is this a problem for the mother?
Yes.
Is it a problem to the fetus?
Yes.
And how are you going to treat this?
I would deepen my anesthetic initially and at the same time give some opioid analgesic.
What is your anesthetic at this time? Do you use an IV anesthesia? Volatile anesthesia?
I don't know. I've not done OB. I would assume a volatile agent.
Okay.
No, you don't want to do that. You would do it. Yeah? Okay. Diana says yes.
In terms of opiate administration, how much are you going to give?
I would give 100 of fentanyl to start and
Why
have
do you
more
choose
ready to
100?
go. It's just a reasonable place to start.
Okay. Moving on. The child is delivered and covered with meconium and has an APGAR of 2. What's your interpretation?
Meconium aspiration.
What does an APGAR of 2 mean to you?
APGAR scores depend on, I believe it's color, heart rate, oxygenation, and activity level. So I don't know what that 2 is coming from, but it's low.
Okay. In terms of resuscitation, what's your plan?
Give the baby oxygen, and if that means mask ventilating them and assisting them, are they spontaneously breathing or not? Then I would assist them on 100% FiO2.
Would you try to deliver anything like bicarbonate? Get an IV access and give bicarbonate.
That wouldn't be my first thought, no.
At what point do you need to start doing chest compressions?
What's his heart rate?
What heart rate
I'd
do you
say,
need to start doing chest compressions?
Below 60 would be my threshold.
And let's presume that it's 65 currently. How else are you going to support this baby?
If his FiO2 if his saturation is still below, I would say 90%, I would attribute the bradycardia to hypoxia. So I would continue my ventilation efforts first and foremost.
What's your threshold to intubate?
If his heart rate drops below 60 and I cannot successfully oxygenate and ventilate the child with a mask.
Moving on. Shortly after delivering the placenta, you note a gradual rise in the mother's temperature from 36.5 to 38.8 over 40 minutes. What's the cause?
I think on my differential would be malignant hyperthermia, but also that she had chorioamnionitis and that she's infected. I would talk to the OBs about what their recommended antibiotic treatment would be and see if we can administer something intra-op. If I have any warming device on her, I would take it off. And if I had any warm fluid going, I would stop and give her cool fluid instead.
Is hyperthermia something that's common post-delivery?
I don't know.
Moving on. The surgeon notes diffuse oozing and after the delivery of the placenta. How are you going to evaluate this?
So if they feel that they need uterotonics, then we said her history was gestational hypertension, we could consider giving a dose of hemabate.
Let's say that the surgeons are concerned about DIC. Why would they be concerned about DIC? What would they be seeing that would clue them into DIC being a problem? Does that bleeding look different than bleeding from, let's say, uterine atony?
I'm going to say yes. I know that you can bleed from your IV sites in all sorts of places with DIC. I'm not sure how it looks different, though.
So let's presume that it is DIC. What do you think the mechanism could be that induced DIC?
Potentially infectious, especially if she's febrile. You can also get DIC from amniotic fluid embolisms, but if she's not showing any other signs of instability, such as hypotension, then I think that would be much farther down on my differential.
Good. That's it.
Woof.
Oh. Yeah.
What's a baby's normal pH? I don't know the answer to that.
CA3s.
Normal, maybe?
Normal
baby
I was
pH?
like, sounds about right. Like, when has this ever been a pleasant experience?
I don't know, it was like 7.25 to like 7.3.
I know, I thought it was lower.
Like range.
Yeah.
Yeah, so above 7.25.
Is lower.
7.25 is kind of the lower end of normal, right? So,
And what is the difference between
Yeah,
the
the
scalp
so
pH?
scalp pH. So it's interesting.
I didn't know it was a thing.
Your umbilical vein
Oh, yeah.
blood versus your umbilical artery blood are a little bit different. They're subtly different. The numbers in terms of magnitude don't really matter quite as much. But the point being is that a scalp pH and a pH from, let's say, umbilical artery are not, they're like 0.05 off. They're not that much different. Typically, the scalp is going to have a higher pH and a higher oxygen content. So what's normal oxygen for a blood gas in a fetus, in a newborn?
Is it super low? Sure does.
It's lower than 50.
Whoa.
30.
Whoa.
It's about 30.
Wow.
25. That's normal. What about lactate? Right, so it's going to be around 4, right? We see a lactate of 4 on our patients that are adults. We start to get a little concerned. That's going to be anything less than 4 is considered to be more normal for a fetus. Let's see here. We talked about pH. Any other questions on kind of blood gases for the fetus? So typically, it depends on what you read. 7.1 more recently has been shown to be a pH that is actually coinciding with some neurologic impact. And so there's this debate about whether, what the true cutoff is to either go to delivery or to prognose whether a fetus is going to have long-term issues. And so right now, 7.1 and less is kind of the benchmark where they're at high risk of having something for the fetus. So that 7.1 to 7.2 range is kind of this gray area. They might be okay, they might not be okay. But if they're below 7.1, they're probably going to have some problem.
What was the question about an antacid and methadone?
Well, let's get to that in a second.
Okay.
So preeclampsia, let's talk about that for a second. The magnesium. Has anybody seen what kind of doses OBs give for magnesium boluses?
They load with 4.
Yeah, that's a lot.
Yeah.
It was like
Like
That's
6
like
to
10
4
grams.
grams. Like 4 to 6 is their therapeutic range.
6 is therapeutic, 6 to 8 is toxic.
Yeah.
But they load with
Yeah,
4 and 10 is like
that's
So I hear some people throwing out like toxicity ranges and stuff. So we talked briefly about this. You have a therapeutic range. A lot of people will say it's around 4 to 8. Some people will say it's 4 to 6. But the point being is some of the first manifestations of toxicity are going to be cardiac effects. What are those cardiac effects?
Oh man, it's either think of
PR interval lengthening out.
Okay.
Is your KRS
QRS widening out. So you could just imagine taking that complex and pulling on it, and everything gets just a little bit wider. So that shows up on ECG before you get any of these other manifestations. So once you get changes there, the next level is where you lose your DTRs. Would anybody say that they would check DTRs?
No.
That's just what we remember from being med students.
I think I
put my thumb on it and then hit my thumb on the hammer, but I don't even remember.
It's funny because I feel like the first thing that we always notice on the floor
and I guess maybe it's just because we never have anybody on telly up there, but you go see them in bed and they're just like off slug.
Yeah.
They're not moving anything. Yeah, they're weak.
So you're exactly right. But DTRs, if you're testing them, you have to have a good baseline to go off of, right? So if you didn't test them before, you don't really know where they were. So that's one of the caveats in this exam format of saying I'm going to go check DTRs. You have to say, presuming I checked them before, I would go ahead and check them. But if you don't know how to do them and you can't talk through them, don't say you're going to check them. So I'm going to consult with my OB colleagues about whether we should check for deep tendon reflexes and see whether they're present or delayed or absent. You can say something like that. The manifestations of a more high level of toxicity are going to be the weakness that you start to see for patients. And that's going to be weakness not just of themselves and the musculature, but also uterine weakness too. So then that also leads to the fetus. So the fetus, when it's born, is going to be a floppy fetus. So you have to think about that in your patients that you're taking to the OR for cesarean section. Mom's been on magnesium for a long time. She's weak. Baby's not going to be doing super hot when it comes out, right? So that's one of the important things to remember for yourself, to keep an eye on the respiratory status, because the pediatric team may ask for your help. Has anybody helped the pediatric team yet?
Yeah. Who's taking care of mom if you're helping the baby?
You're attending.
Oh, okay. I'm just like, hang on, mom.
Yeah.
See
Yes.
ya.
Yes.
She's gonna put your baby. You can bleed out a ton.
And then, of course, once you move past the weakness part, you get stupor, you get kind of the ultramental status changes. And then people that die from toxicity, how are they going to die? It's usually going to be cardiac arrest, right? So you start to impact SA node and AV node.
15.
Right.
Yeah. I remember that. What's your, is there a correlation between your mag levels, 5 to 7, 7 to 10, 10 to 15, 15 to 20, like calcium chloride dose to offset? No, there is none. Okay.
So just like we talk about with most things that we give, titrate
to effect.
Right.
Cool.
And what is your effect here? What are you looking for?
Well, if I have the EKG changes, then I would want to see a shortening PR and a narrowing QRS.
Strengthening of the contraction, strengthening of the patient. What's that?
At what interval would you give more?
Again, there's no paper that's going to tell you the interval. I think in most cases, you do it faster if they're more symptomatic, right? So maybe every 5 minutes initially, maybe every 15 minutes after a while.
That's what we just said. We were like, slam it right in. Hypertension.
Opioid addiction. So I got you a little bit confused, I think, during that part.
Yeah.
So naltrexone, what is naltrexone?
Partial, yeah, it's got a partial, yeah.
Like a
Mu agonist
It's a
kappa.
full antagonist, right?
It's the box.
So,
Oh.
yeah.
Yeah. Naltrexone and buprenorphine is exactly what you were saying. If you inject it,
Right.
it takes away that whole
Yep.
partial
The high,
highness.
right, yeah.
But what's the difference between naloxone then and naltrexone?
Just duration of action.
What?
Just duration of action. They're the same, aren't they?
Well, so they are, but typically naltrexone is going to be an IV formulation and naloxone is a PO formulation typically.
Wait, so why is our methadone addict on naltrexone?
So it was in place of. So the question
He said,
was,
what if she
if she wasn't on methadone but instead was on naltrexone, would that change your management?
Oh.
So why would a patient be on naltrexone then, just as a single agent?
Alcohol abuse, right?
So typically alcohol abuse, it's a way to prevent alcohol use, but it's also used in patients that have opiate dependency. How so?
It's given as a long-acting injection.
But it also decreases cravings, right? So that's one of the bigger pieces in this kind of addiction treatment approach, is that you decrease cravings. And that's going to be true for really most addiction type things, whether that's opiates or benzos or other things. And it shuts down that reward pathway.
Somehow, I feel like somehow, was it explicitly said? I feel like we went from like a walk to the OR briskly kind of thing to a she's going to sleep right away
To a we
kind of
need to
thing.
cut
And
right
I was
now.
like, was that like group think where we all of a sudden?
No, he kind of changed it. He's like, what if the OBs are saying cut right now?
Oh, gotcha.
And then,
Okay.
you know,
I was
so-
like, so I feel like upstairs you always get in the situation where you have to be like, whoa, can somebody just tell me?
Right, which
how
is
quick
it?
is
Yeah.
this needing to happen?
I said that like twice today.
So I was like, I feel like I didn't know if I missed the tipping point or if we group think our way into she's going to sleep.
Yeah, she clarified.
Okay.
And during these, does anyone listen to the ACRAC podcast?
Yeah.
He has a really good oral board when they did an OB case, and they would say, oh, if I have time, I would do this. If I don't have time, I would do that. If this were the situation and it was changed in this way, they would kind of preempt all of the questions, and then they don't back themselves into a hole.
Yep.
So
that's the overriding strategy that I try to get them to not ask questions. I know the two of you ask a couple of questions. You want to drive it in the direction that you want it to go, and that's exactly what they're describing. So you put it in your safe area, your knowledge area, and you force them to take you out of it if they want to or need to. The pre-medication stuff, so what are the antacids that are given up on OB before they go back for an elective procedure?
I get Citra.
Yeah. So a non-particulate agent.
Does the research show that actually? Yeah, I didn't think so.
there was an old paper Mendelsohn did that it's probably the best data for it.
Yeah, that's not very good. Now, in terms of the drugs altering the activity of methadone or opioids, does anybody have a sense of what medications could?
PPI, yeah.
Right.
My biggest concern.
There's CYP inhibitors, so they'll alter the metabolism.
Yeah. So PPIs, generally speaking, are not things that we would give in the anesthesia world. We're going to stick really with H2 blockers predominantly, non-particulate antacids as well. Any questions about the pre-op portion?
I think thinking about a multimodal approach to her if you would be reasonable as well. Around town or I don't know, just a thought, in addition to all the other stuff. It's not going to be difficult. Which is involved.
Just leave the catheter in for 24 hours.
Well, it's all on the OB order site, we just never see it. Because they're getting those overhead forward.
Is that different for eclamptics or preeclamptics who are at risk for HELLP syndrome?
That's why I-
Tylenol.
Well,
I think that it's on their standard orders.
it is.
But I think the timing often is such that the nurses are probably, I don't know if they're instructed within the orders or if it's just part of their practice, but they wait for these labs to come back before they give stuff.
They don't wait for the platelets to come back before they call us, but they definitely wait for those labs to come back.
All right, intra-op, I thought you did a great job talking about general anesthesia versus regional anesthesia. I mean, that's always the thing with these preeclamptics. It used to be really thought that a neuraxial approach was going to be harmful to the fetus because of that sympathectomy piece. And that's not shown to really be true. So the sympathectomy that these patients get, they might go from 170, like this patient, come down into the 130s or 140s. They will drop, but usually into a more acceptable range from your standpoint. And I think Joy's overall feeling is that do neuraxial whenever possible. And really just general anesthesia is a last resort. And that's really that key there of knowing your time, right? So if the surgeon says, we need this baby out now, you don't have time for a spinal. You don't have time for dosing the epidural. The neonatal resuscitation, so the APGAR, what does APGAR stand for?
Was a guy's last or a lady's last?
Yeah,
It's been back.
Yeah.
That been extensive.
Posture, grimace,
So P is pulse.
pulse.
We can tell you had a child recently.
Yeah.
G is grimace. What'd you say?
Activity and respiration.
Activity. And appearance. So appearance is the color, essentially. Grimace is why they rub them really hard and they try to get them to cry, right? Get them to react. Pulse, what's the number that they want to see? Greater than 100. Color?
Pink.
Yeah.
Not blue.
So color turns out to be the thing that when you're in the OB floors and you see patients that are delivering, the appearance or the color is going to be the one that most often is going to be that 1 or marked down. It's not a 2 every time. It's a 1 or a 0 depending on the color. Most babies don't come out really pink.
Especially here.
Right. And then the R is the reflexes. So what is the reflexes of the baby?
The startle. Yeah, they like go out. Yeah.
So they're flexed, right? Flex at the hips, flex at the arms. So they try to be curled up. And so if they're floppy, it's obviously not good. So an Apgar of 2 is bad, right? Apgar of 2 is a baby that's going to be probably needing to have some significant resuscitation.
Is there any Apgar score at which you would just intubate, or is there I don't know what the criteria are for tiny children, but
No, when you see the pediatric team in there, they are really slow to intubate.
Yeah.
They will mask for a long time.
Mm-hmm. They'll CPAP.
They like mask all the babies.
Because once you intubate those neonates, it's really hard to extubate them.
And they really rely just on hearing the breast sounds as well as seeing some chest rise with their bagging that they do and support that they do. I unfortunately had a case that I did, it's been almost 3 years ago now. The senior resident believed that the respiratory therapist had something wrong with her bag because chest rise wasn't happening, there was no breast sounds. But it turns out after they had done some kind of investigation, after they intubated this baby, that the peak pressures when they intubated were like 45. So this bag was unable to generate a positive pressure enough to actually move any air. So it was a really bad situation. But that's when you're watching them bag, that's in your mind what you're looking at. You're looking at, do I see chest rise? Is there any change in the heart rate? Their heart rate changes very quickly. They get good oxygenation, it bounces up really fast.
Why were the peak pressure so high?
Meconium aspiration.
Okay.
And they don't suction for meconium aspiration anymore, right?
there's always the wrong answer in True Learn.
They suction, but they don't try to get down.
Deep suction.
That's right.
You don't hang them upside down like Spank.
Hyperthermia. Anybody know
Well,
about
it's supposed to be,
women getting hyperthermic after delivery?
it's also the uterotonics.
Almost all of them, right?
Side effects.
I mean, even when we don't intervene, so women that have babies that are without an epidural, just natural delivery, they also get hyperthermia. It's very common. So that's always a big differential piece for the OBs is at what point do you start to treat? When is it a normal fever? When is it an abnormal fever?
Is there a cutoff?
Yeah, I was gonna say,
There's
does it have a
a
number?
laboring, isn't it? If you've been laboring for over 24 hours.
I don't know the answer to that. I would presume that 38.8 is probably abnormal. I think that most temperatures that I've seen for my own patients post-op will be more on the order of 37.5, 38 tops. I think 38.8 would be too high. DIC, I thought you answered that beautifully in terms of the things that you would look for. So, the causes, I think there's one that maybe on the timeline of this probably wouldn't have made sense, but if it were somebody that were, say, taken out of the operating room and they're continuing to bleed, so retained products could be one component as well.
I guess
were asking
DIC
if it
bleeding
looked
is just
different.
like, I'm thinking, I guess now is that just it's oozing from all
Everywhere.
over the uterus rather than like from their incision.
All surfaces, right? So it's
And it's
everywhere.
probably still involuting, unlike the big floppy uterus, but you're still getting bleeding.
And you probably would still get normal tone, assuming the uterus is still responding to everything normally, which it should. So the tone would actually be good, but you're still getting a lot of bleeding.
Could you say like look for petechiae at their IV sites and things
Yep.
like that?
That's exactly right.
Oh.
Any questions about any of these things that we've talked about?
What's the timeline we have like retained products? We were talking about this the other day, like when they would develop DIC.
I think it's a long time. I think some women have actually gone home, been discharged home, and then they come back for bleeding.
I had one. Yeah, she came back like 2 days later for a DNC. She didn't have DNC.
But yeah, it's a long time course.
Probably was like a week or something.
Yeah.
I didn't know.
And then you can have chronic seizures up to 4 weeks after delivery.
And I guess the one piece we didn't talk about, so this has changed, the terminology has changed a little bit, and actually probably since you were a medical student it's changed. So preeclampsia versus preeclampsia with severe features. So what is that distinction then? What is preeclampsia with severe features?
You have a certain amount of protein in your urine.
Yeah, the PTCH is
So
good.
proteinuria.
Neurological symptoms. So end organ problems.
So end organ problems. So what are the end organs of
Liver, like health. Neurological problems. They could have headaches, confusion, kidney.
Vision changes.
Kidney injury and vision. Pulmonary edema.
Yep, pulmonary edema.
What about requiring more than 2 antihypertensive agents? Do they consider that to be, it's just kind of one of their like background markers for when they start getting concerned?
Kidney function, right? So what is a normal creatinine for a pregnant woman?
It's low. 0.3.
Yeah.
It's low, right? And so it's low, usually 0.3 to 0.6. I mean, they hyper filter. And so above 1.1 thereabouts is considered to be evidence of kidney injury from preeclampsia. So those are the big things. Platelets also being one. So platelets less than 100,000. The blood pressure is something that nobody's talked about yet. So blood pressure alone with proteinuria, what is the cutoffs for preeclampsia with severe features?
A gram.
Blood pressure.
The systolic greater than 160.
40.
That was 140 over 90.
So 140 over 90 is the cutoff for preeclampsia.
160.
Severe is
160.
160.
Or 100.
110. Yeah, so you go up 20 on each of those numbers from just regular preeclampsia. So this woman coming in at 170 over 100, she would qualify then for preeclampsia with severe features based on blood pressure alone without having a urine analysis done to see if she has proteinuria.
You have to read both the systolic and diastolic pressures or either?
Either. Yep. Anything else? All right. Thank you, guys.
Thank you.